laparoscopic entry is a blind leap of faith unless you know exactly what lies beneath the skin. In this masterclass, we are mapping the three critical safe zones and the major vessel danger zones that every gynecological surgeon must visualize before the first incision. Wherever you are preparing for the MRCOG part 2 or 3 or your next list, this is the surgical roadmap you cannot afford to miss. Let us start to bridge this gap today. What we will cover today, we will scale the problem. What is the incidence? Why the college make a separate guideline? Entry techniques comparison, the pressure technique, confirming the placement, alternative sites and ports, and special population and training. What about the serious complication occurs? It's about 1 in 1,000. Laparoscopic overall range 1 to 12.5 per 1,000 across studies. In the largest Dutch multi-centric study, 57% of all injuries were attributed to entry technique. Bowel injury is often not recognized until after this discharge. What is the only blind step in the whole operation is the entry. Why entry is different? It's a blind step. Skin incision, needle trocar insertion, then insufflation, finally visualization, confirmation. Danger zone, everything before visualization is done without direct sight. This is a problem. Once the laparoscope confirms a clear peritoneal cavity, risk drops sharply, of course. Almost every strategy in this guideline exists to shorten or de-risk this one window. What about the three ways? What is the entry technique? We will make a comparison as we promised in beginning of the video. Veress needle, closed technique. This is preferred for the obstetrics and the gynecologists. Insufflate before trocar insertion, traditional gynae default. Bowel injury 0.4 per 1000, vessel 0.2 per 1000, important number from meta-analysis. Switch technique after two failed attempts. After two failed attempts, you have to switch the technique. It's an MCQ. The grade C, the Hasson or open technique. It's direct vision entry, no sharp instrument after skin, and it is Royal College of Surgeons preferred, but not proven to be safer. Bowel injury 0.6 per 1000, higher risk in the best comparative review, and no reduction in vessel injury. For the third technique, direct trocar insection, skip prior pneumoperitoneum, fast in experienced hands. For 6 randomized controlled trials, no disadvantage on major complication versus Veress needle, possibly fewer minor complications. And the Cochrane meta-analysis of randomized controlled trials shows no technique is definitely safer for major complication. Training and matter more than the choice itself. What about the safe Veress needle entry step by step? Position and palpate. Table horizontal, not tilt. Palpate for mass and aortic position. Second step, vertical incision at the base of the umbilicus, not below it. Third step, insert at 90 degree, sharp tested needle to audible clacks, fascia, then peritoneum. Confirm placement, insufflation pressure under 8 mm mercury flowing freely, and insufflate and insert a trocar to 20 to 25 millimeter mercury, important number. Then rotate scope 360 to check for adherent bowel. These 5 steps are important roadmap. You can make it as a checklist before going to the operating theater. What about the pressure? Get in and the pressure to work in important numbers. Always exam trap 20 to 25 before primary trocar and 12 to 15 once trocar are in. It means that 20 to 25 millimeter mercury to get in and to work in, it will be reduced to 12 to 15 millimeter. At 25 millimeter plus 3 kilogram of force, the abdominal wall stands of the viscera by 5.6 centimeter versus just 0.6 centimeter at 10 millimeter mercury. That extra clearance is what protects the great vessels. No adverse cardiorespiratory effect if the patient is supine. What about what is confirming that you are in the right place? It's a very important step, confirming the right place, and unfortunately, no test is 100% accurate. Every classic click or his test has false positives and negatives. So, what is the best practical sign? Initial insufflation pressure under 8 millimeter flowing freely. And then 360-degree rotation back, important step as we explained before. Rotate the scope fully after primary entry to check for adherent bowel. Recheck on exit is important step. Don't miss it out. Inspect the umbilical site under vision while withdrawing the scope for through and through entry. When the umbilicus is the wrong choice, there is special circumstances. Palmer's point preferred alternative use when adhesion expected at the umbilicus. When there is a previous surgery, avoid if prior surgery in this area or splenomegaly. Umbilicus default, no risk free. Adhesion rate 50% after midline laparotomy and 23% after low transverse incision. This is important number. Suprapubic funnel, posterior fornix generally avoid the bladder injury, infection, rectal perforation risk depending on site. So this is the dangerous zone as we explained. What about after the primary port, beyond the primary port, the secondary port? Insert perpendicular under direct vision at 20 to 25 millimeter mercury. Visualize the inferior epigastric vessel first. Very important critical step. Hernia prevention close deep teeth for any non-midline port over 7 millimeter or midline port over 10 millimeter. Important exam trap and very important in the practical clinical practice. And for the obese women, Hasson or Palmer point is preferred, as we explained before, if Veress used in size deep at umbilical base. Vertical distance to peritoneum averages 6 centimeter. For very thin women, Hasson or Palmer's point again preferred. Highest vascular risk group, aorta may lie under 2.5 centimeter below the skin. So building a safe laparoscopic surgeon, this is the roadmap of the Royal College explained in the guideline for the training, core training, then benign gynae laparoscope, and then mentored complex cases. This is 3 stages for safe laparoscopic training. About our safe entry zones, very important map. Safe entry zones, the umbilical safe entry zone, base of the umbilicus, where skin sits closest to peritoneum. Key landmark, 45-degree Veress angle if non-obese, 90-degree at higher body mass index. The umbilicus shift caudal to the bifurcation as body mass index rise. Palmer point, the backup zone, 3 centimeter below left costal margin, mid-clavicular line. The danger zone here is the spleen and the stomach. A key landmark, decompress the stomach with an orogastric or nasogastric tube before entry recurring. It's MRCOG exam point as well. What about the third safe zone, lateral vessel free zone? What is the safe zone? Lateral to the rectus abdominis muscle. The danger zone here is the inferior epigastric artery, and confirmed by trans-illumination or by identifying the medial umbilical ligament laparoscopically before secondary trocar. For the umbilical safe entry zone, um, safe zone base of the umbilicus where skin sits closest to the peritoneum, and the danger zone is the aortic bifurcation as little as 2 centimeters away in thin patient. Important. The key landmark here is 45-degree Veress angle if non-obese, 90-degree at higher body mass index. The umbilicus shift caudal to the bifurcation as body mass index rise. Okay, finally, two things every unit should track: documentation of appropriate counseling, it's very important, clinical incident reporting of all adverse events and complication, and the take-home message: no single entry technique is proven safest. The pressure technique, careful anatomy, knowing when to switch approach are what actually reduce injury. Finally, hoping you find this video useful. Thank you for your attendance. Subscribe for the channel and see you next video. Thank you.